Western civilization is moving closer to a point of irreconcilable, unstable equilibrium, as frighteningly increasing numbers of people trust nothing. Media, academia, and especially the governments are no longer held in high esteem. Regaining trust is often impossible after betrayal. However, transparency is essential to any healing process, and that is the essence of the Don Sullivan Show. Please listen to the team explore, probe, and debate cutting-edge science, technology, and computing. Play ball!
Welcome to a very special episode of the Don Sullivan Show. As you can hear, Don is currently on the road, and you're going to learn more about that very shortly. I'm your co-host, Jersey Steve. First, we want to thank our sponsors. Today's episode is brought to you by License Fortress, the industry's first and only software asset management firm to offer both a financial and legal guarantee at its highest level of service. Whether it's Oracle, Microsoft, or VMware, License Fortress helps organizations stay compliant, avoid audits, and save money. You can learn more at licensefortress.com. And please support our producer, our wonderful producer, Bill Axt, by visiting axtinc.com. That is AXTINK.com. You can subscribe to his YouTube channel and help support his efforts to create humorous animation, as well as run our website, all while researching a cure for baldness.
Hello, folks, again. Welcome to the Don Sullivan Show, the show where we talk about everything science, technology, and computing. And as I told you in last episode, we're taking a wonderful, luxurious river cruise, and we're on the Rhine now, heading towards Paris. And I wanted to take the opportunity, as I am here with my good friend and former teammate and lifelong brother, Dr. Theo Hodge, who has been on a number of good friend of the show for a lot of different reasons. In fact, our inaugural PG-13 episode, as well as a number of other shows. We're going to talk about a little bit of a different subject today, a very important subject. I'll tell you what that is in a minute. Once Theo says hello. Say hello, Theo.
Hello. A pleasure to be with you, Don.
Once again, Theo's going to have to start paying him. I have to start paying you, Theo?
No, you do not.
Oh, okay, that's good. So today what we're going to talk about is an interesting medical subject within the medical series of the Don Sullivan Show. Specifically, we're going to talk about the need for physical therapy. Now, I've had Brad Marquez on, expert, lifelong physical therapist from physio practice, to talk about some of the mechanics and some of the actual techniques and needs and functions of physical therapy. What I wanted to do was to have a discussion with Dr. Theo here about the need for continuous physical therapy, for proactive physical therapy, from a perspective of a general practitioner, an internist, as opposed to someone who in the medical field has a vested interest, such as a orthopedist or a physiotherapist themselves, or any kind of physical therapist or an athletic trainer. There's lots of those, but I really want, even though Theo and I both obviously have lots and lots of background in all of those areas, both good and bad, meaning victimhood and being victims as well as being proponents. Theo, of course, is a general practitioner, internist in Washington, D.C., as we have introduced him before. We're going to have him talk here in a little bit about some of those things, but I really want to get his perspective on the need for physical therapy. And of course, we're doing this as we're sitting on the top deck of a river cruise ship, the name of which will remain anonymous at the moment until they become sponsors of the Don Sullivan Show, as we are floating up the Rhine towards Paris. So, Theo, talk to me a little bit about just what it is that, as a general practitioner, you see in terms of the physical fitness of your average patient, and how their life would be enhanced if the overall American medical system was a lot more accepting of, a lot more proactive towards physical therapy. Just physical therapy itself it is proactive. It's a proactive way of dealing with all kinds of physical problems. So what do you see in general?
So in general, Don, I like to tell people, look, in terms of how I practice medicine, it's a patient-centered thing. The patient's voice is heard in any decision that is made. And my general approach is mind, body, and soul. So when patients present with the various things that might actually have physical therapy as a possible treatment plan, which in general would be, I have low back pain, I have low back pain, I have back pain, I have back pain, I have low back pain. Or I have shoulder pain, or I have hip pain, or I have knee pain. Any of the joints, but back pain by far is the most predominant thing that patients will present with in my examination room. We sit down and talk about the basic algorithm. And remember, algorithms can be changed. And again, in a patient-centered setting, the patient's voice is very important as to how one will proceed through an algorithm. So if you presented to my office with acute back pain because you were out
back pain where mostly lower back or neck,
so it's
or anywhere in between.
Anywhere in between, but is usually lower back pain. And it's usually because the patient has come in and said, well, I just helped move my daughter from her apartment in college to her home.
This is your average 45-year-old, 50-year-old.
You got it. They're usually middle-aged, and middle-age, I will say, starts at around 40, 45.
Your patients have been around for a long time with you.
They have been a long time.
So they've been patients of yours for a while, so they're no longer young.
Nope,
so you've seen them for a long time, and you know about all of the pathologies that they have put themselves through.
Exactly. This is my 30th year of practice. So as you can imagine, I started in my mid-30s, and now I'm not in my mid-30s anymore. So when patients come in to see me, yeah, they're usually middle-aged. They've just done something out of the blue. They're not usually lifting heavy objects, but suddenly they did for a weekend to help move a child or other family member, and they come in my office saying...
By child, he means a college kid.
Exactly. So they come into my office and they're like, ow, 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 ow. Do something about this, Dr. Hodge. Ow.
So they're going to come to you for what is obviously an orthopedic issue to begin with.
That's exactly right.
They completely trust you in every possible way, and you're probably not initially going to send them to some highly expensive orthopedist. You're going to try to deal with the problem with some type of topical or simple approach. But this is where the physical therapy potentially comes in, right?
That's exactly right, Don. So yes, typically when someone's coming in with low back pain, they're not going to immediately say, I'm going to go see an orthopedic surgeon. They're going to make me their first stop. And if it was appropriate, I might say, hey, I need to get the opinion of a specialist, such as an orthopedic surgeon. But typically when you've done something acutely, the typical algorithm is anti-inflammatories. That's your usual ibuprofen or naproxen. Occasionally I'll say, hey, if this is really bothering you at night when you're on your back, I will add a muscle relaxant, because muscle relaxant will help relax those muscles that you have inflamed because you have lifted this heavy box. And it'll also put you to sleep.
Or many.
Right, exactly. So the muscle relaxants also have the side effect of making you sleepy. So if you take it at night, it's very helpful. And then the third thing, which depends, if you just had this happen, and it's only been 2 days of pain, I would just say, hey, let's do the anti-inflammatories and the muscle relaxants. But now if you're entering week 2, then I'm like, okay, we need to add physical therapy. And physical therapy, I can tell you, over my 30 years of practice, 85 to 90% of lower back pain is addressed and made better by participation in physical therapy. And I make my patients commit to it. If you're going to do this, you're going to do it. You cannot go and only do one session. You have to do the appropriate amount of sessions, which will be determined by your physical therapist, because they will do an assessment and they will say, hey, we're going to do these exercises for this period of time. And if you're going to do that then you have to commit. And I will tell you that over the time I've been practicing, when my patients have not only committed to this and improved with physical therapy, don't get me wrong, I still have to use the other things such as anti-inflammatories and muscle relaxants. They learn the exercises that they
Do they do them?
They do them, and there are patients who will say,
Your patients are better than people I know, because when certain medical institutions like Kaiser has patients go to a single physical therapy visit and hands them a Xerox form of exercises to do after that, I've just seen almost exclusively that people wind up not doing them, at least not doing them nearly as well as they should, or not doing them for as long as they should, and not being nearly as effective, which is why I'm such a proponent of the hands-on physical therapy, both from a medical perspective and a business perspective, because it can be so proactive. I look at two different forms or two different categories of physical therapy: the proactive and then the recovery-based physical therapy. The proactive physical therapy meaning when you have the problems that you've just described. They're usually minor problems, but they're also indicative of a likely future major problem. And so if it can be addressed in physical therapy, strengthening and flexibility-oriented, range of motion being the most important aspect of the physical therapy, if you can address that, get somebody back to where they are healthy, then they're going to be much less likely to have a major problem, which is going to be much more expensive to the business. So, although you seem to think that your patients are listening to you, do you think that's common?
Well, I would say this, Don. Typically, when I'm sending a patient to physical therapy, it is definitely more than one session. That never happens.
Is there insurance companies let them know at this point? I mean, they did in the 90s. And it's certainly not, as I said, with some a huge conglomerate like Kaiser. They have a philosophy that is contrary to physical therapy. I can say that with certainty. But you don't think that's true?
So I can tell you this. I am not part of Kaiser, so I cannot speak on the typical allotted amount of time that a Kaiser patient would have with a physical therapist. The insurances I deal with are commercial, and they're all outside of Kaiser. And typically, someone's going to have at least 3 to 6 sessions. The physical therapist does an assessment, faxes me their assessment, and says, hey, the patient is going to be involved in these exercises over this period of time. If you agree, sign this. If you disagree, then let us know, and we will do a reassessment. So typically,
that's where you get the peer-to-peer conversation sometimes.
Exactly.
Be a little bit more cajoling and convincing of the need for it.
And many times my patients have to go more, 2 or 3 weeks. And I've had patients the first week, they're like, this is not working. And I'm like, hey, you need to give this a chance. I mean, although you did this over a short period of time, the consequences in terms of resolution is going to take more than the 2 days that it took you to do this. So this could take 2 to 3 weeks, sometimes 3 to 6 weeks. And typically, as I said, 85 to 90% of my patients do respond to physical therapy. And they end up coming back to me saying, hey, this is the physical therapist I saw. You need to send everybody to this person, So, and it's very important, I think, that people understand this, because certainly in medicine, people love to do all these imaging studies. So if someone came to me with acute lower back pain, I am not getting an MRI. That just, no matter what the MRI showed, I'd still do the initial thing, which we would consider conservative management of anti-inflammatories, muscle relaxants, and physical therapy. So an imaging study is not necessarily the first thing that people should do. So often people come in my office and say, my auntie said that I should have an MRI. And I'm like, really? Does your auntie have an MD? And if she does, then she can order your MRI. But
I would think the auntie, if you're really hurt, would at least ask for an x-ray first.
Well, and that's the thing. And even an x-ray, again, you're like, okay, what is this going to tell me if you're having acute back pain? Now, granted, let me be very clear. If you came in and you said, hey, I can't, I'm weak in my legs, I can't walk, I have balance, difficulties, then yeah, that would necessitate me being very aggressive, and that would include imaging. But I helped move boxes because I was moving my daughter, and now I have pain that is just, concentrated or localized to my back. That does not necessitate an imaging study, because as I said, no matter what the imaging study said, you're still going to be very conservative about your management. You're not going to send the patient to a surgeon. That's just not going to happen.
So let me ask you a PG-13 question. So all the lower back pain is caused by people moving around boxes. How often do you think it is people trying to have sex and they really can't anymore? Or at least their bodies don't move terribly effectively.
Well, I can tell you, in my patient practice, no one would ever dress that up. They would just tell me, look, I was trying to do a backflip and it just went the wrong way. So,
well, okay. Now that we have delved into the PG-13 part of it, we'll go back to the real world, the other world. What I do want to know, though, from a perspective of the physical therapists themselves, there's kind of a number of reasons to send somebody to physical therapy as opposed to hoping or instructing them to do it on their own. There's both the hands-on work, the massaging, which is not like just going to get a massage on a cruise ship. They don't have them on a cruise ship or on, but there's a lot of masseuses out there who are just there to provide relaxation, as opposed to a physical therapist doing that type of transverse friction massage, for example, to break up scar tissue. That is highly unpleasant and not something that you can do on your own. And many other types of deep tissue types of work. I mean, obviously dry needling and other things that you have to be certified to do, and it's actually kind of dangerous. And the other part of it is just from a supervisory perspective, we think of it as coaching. And as much as some people, and apparently Dr. Theo's people are better than the people that I know in this regard, are able to do a lot on their own, some people are, a lot of people aren't. People have not grown up as athletes. And as they get older, they become less and less inclined to even sit on a stationary bicycle or walk upstairs if they don't have to. And so telling them to go do these exercises with a Xerox sheet, even after they've had 6 or 7 visits, to maintain or to get better, to get stronger, to get more flexible, to get greater range of motion, is I think a much less likelihood. And it's one of the reasons why actually going to real physical therapists, especially the old school physical therapists, as opposed to the newer versions that are very cost sensitive, we'll put it that way, is to me tremendous value. Do you agree with that?
Oh, I wholeheartedly agree. And don't mistake me, my patients are just like anybody else when it comes to, they're much more likely to participate and engage when they have a coach or someone who is there motivating them. So even if they've had, and so often I've had patients who've had physical therapy,
directing them, coaching them, instructing them.
Exactly.
Yeah.
So often I've had patients who've had a history of low back pain, and so they had physical therapy 10 years ago, and although they may know the exercises, they certainly can and do actually have improvement in their health by being re-engaged to a physical therapist. So I do that all the time, and my patients are famous for saying that, well, I did this 10 years ago. I'm like, well, guess what, you're going to do it again. And they always
better do it again.
Exactly.
Or it's going to be worse 10 years from now, not worse.
Exactly. And they always, I'm telling you, 85 to 90% of the time, the patient actually has a benefit from re-engagement. And this is,
it's because Theo's a good doctor. They believe him.
Well, I mean, it's conservative management. I mean, no one wants to end up on some surgeon's table to address a back issue when they don't have to. If you can do conservative management and have an enhancement of your quality of life, because that's what it's all about. It's all about your having, an improved quality of life, or at least a return to quality of life when you walk into my office. That's my job. So if you can do that from a conservative standpoint, then hey, why not? And that's what I have to always remind people, because of course, what they want what anybody wants is they want instant relief. They're what I want this gone now.
Why that pill works so well.
Exactly. So
Even as opposed to more long-acting and anti-inflammatories. You take an Advil, 20 minutes later, you're feeling better a little bit. You think the problem is gone, and it's not. It's really the symptom is just covered over.
And that's what I have to get patients to buy into. I'm like, okay, this is not a problem that's going to be instantly addressed by the use of anti-inflammatories or muscle relaxants. Yes, we can address the acute pain management, but over the long term, in terms of you're having long-lasting relief, we need to engage in a different process, which is typically physical therapy. And getting people to buy into, hey, this is going to take time, is really a big part of my job. Of having people understanding and recognizing that, hey, this is not going to be resolved overnight, or even sometimes in just a couple of weeks. Sometimes it will take longer than that. And getting people to understand that can be quite difficult at times. But most often people do get it. Okay, hey, I don't particularly like the fact that I have to do this, but it is overall going to enhance my quality of life, and so I am willing to engage in the process.
All right, so let's address a different problem that's purely American. Here we are, floating between Germany and France, which all through the 20th century was not always the most friendly thing to do, and now it's a tremendously friendly and leisurely thing to do in the European Union. But one of the things we notice is how overall the level of fitness here in Europe, and this is a cultural difference, a difference in lifestyle, but it's a difference that is incredibly profound. It, of course, has to do with a lot of things, the least of which is not the amount of time Americans spend at work and the level of stress Americans generally have. But I would love to see just a simple study on how much time Americans spend watching television, particularly cable news. One of the things I've always said, if people watched 30 minutes less of cable news than 30 minutes more sex, the world would be a lot better place. But more without being terribly flippant and delving back into the PG-13 area, I would love to know how much time the average American spends watching television, sitting on a chair and doing nothing, as opposed to that's the time they could be doing their own physical therapy and stretching, or at least part of it, obviously sitting on an exercise cycle of some kind or a rowing machine, but mostly just stretching and the range of motion work, and that's when they could be doing their physical therapy. Am I exaggerating, being too hard on Americans right now, Theo, as we sit here on the floating down the Rhine, watching all these people on bicycles drive by at the shore?
No, I don't think so, Don. I lived in Germany for 3 years. I was in the northern part of Germany. And you're right, there are some cultural differences. In Germany, people were walking, or biking. And, part of their routine after dinner was to go for a stroll. That was one of the things I would hear all the time. Let's go for a stroll. And you would go out and you would see entire families walking. And they would walk for a good half an hour to an hour after a meal. And they, this was a typical thing for them. And of course, when we talk about, what our exercise habits here in the US
the food is a problem too, which is certainly being addressed by cultural changes in the United States now. But
Exactly. And I will give you another example of where, in terms of weight, I was in Tokyo and for the first time, and I noticed that I didn't see any overweight people at all. And I was like, wait a minute, maybe I'm just in a special part of the city. And then when I Googled it, I found that Japan has the lowest rate of obesity in the world. And so, of course, you're wondering, well, is that true for their younger generation? And you find out that, yeah, it is becoming an issue for the youngest generation in Japan because people are spending less time exercising and they're eating McDonald's. not a slur on McDonald's, but in terms of fast food in
Well,
general.
they're eating conveniently fast food. Their lifestyles in, of course, Japan are becoming, and have been for a while, they're becoming much more intense. And they just simply have, the convenience is overwhelming and compelling.
Exactly, I would agree. But all those things, you can see, well, in terms of looking at what's different between a typical American and someone living overseas, you can see, hey, this is why you may see some of the differences in weight. The same thing in France. I can remember sitting there in Paris looking at all these older people, and they, I'm like, how is it that you can look like this? And they would tell me, you Americans, you Uber. You take lift. We walk. And of course, when you get to the metros, you realize
Theo's attempt at the French accent. I don't mean to start a war here, although the French would just surrender pretty quickly. But beyond that, okay, go ahead, Theo.
No, but it makes a difference. They say, hey, our metros, we have to walk up and down the stairs while you ride along and escalators, or you use elevators. So when I was last in Paris, I don't remember seeing a single escalator. And of course, the Parisian might say, hey, you were at the wrong station.
Okay, there isn't the Eiffel Tower. We'll give it that.
Well, that's the Eiffel Tower, but not for your routine metros, which is, of course, how many people in Paris, get around. So again, I think there's a difference in terms of how much physical activity that people are engaged in. And you know that whenever you see your primary care provider, the typical answer to whatever question you're asking is diet and exercise.
Well, this going back to the whole point of physical therapy, looking at it again as a proactive approach towards health, particularly orthopedic health in this case. Do you see a huge difference between younger people versus geriatric people in terms of the basic approach? I mean, obviously, younger people, especially, setting aside the people who are athletes, which is your average younger American who's 30 years old and working 60 hours a week versus a retiree at 70 years old. Is there a lot of difference in their attitudes and what they have to do? Obviously, the volume is different and the capabilities are different, but am I wrong? It is basically the same stuff for the most part.
It is the same stuff, and it depends. I mean, there's some cultural and ethnic differences. People might
Ethnic, really? You think so? Huh?
Oh my goodness! So for my African American men, they will wait until half their face is on the floor from the stroke they've had before they've come into the office to assess whether or not they've had high blood pressure. So I'm really.
Why is that? I mean, why is that cultural?
I mean,
Just not wanting to feel weak.
Well, and that's part of it. Part of it is, why would I say
I would never do that.
No, never, not you. But part of it is, the whole masculinity thing. Hey, coming to ask for help is a sign of weakness. It's not part of being masculine. And I think my younger generation, they're like, oh, boot that. We want to live forever. We want to do every single thing we can to live the best life we possibly can. So I have people in my office in their 20s getting physicals, as opposed to my people in their 70s who really should have a physical every year. I have to pull their teeth.
They don't want to have their blood checked until their first heart attack.
Exactly.
That's kind of a cliche, because sometimes you don't have an opportunity for a second heart attack.
Exactly. That's the thing. My whole thing is, of course you feel good until you don't.
Well, and this is sort of a secondary side effect of the physical therapy, and obviously one of the ways to test for heart problems is a actual walking stress test, and if you can do that, it's almost like a crossover between what is proactive physical therapy and actual much greater in-depth, in this case the heart, physiologic testing, really to determine whether or not you're about to drop dead or not.
Exactly. I mean, preventative medicine is really a good thing, and so many people don't understand and recognize that.
Well, so many companies don't. And again, this is what I don't understand about the insurance companies in general, that the notion of you really can do a relatively simple ROI calculation on this. And I know obviously they've all done it. They're all financial organizations, and that's how they have become as unbelievably wealthy and capable big as they are. But it seems like they are missing that basic, simple point that physical therapy, along with other proactive cares, are going to be useful and good at any time in life. That's where I was going with that.
Exactly.
Comparison between the younger people who are not necessarily athletes versus somebody who's effectively geriatric. That these kind of proactive approaches, it's like brushing your teeth before you have a cavity. I mean, obviously we do that, but we don't really take the time to maintain the range of motion, which I know I've mentioned a couple of times here, but that just seems to me to be the ultimate test of where somebody is at in terms of their flexibility and their overall strength. If you don't have strength at the end of that range of motion, at some point you're going to slip on the pavement, and that range of motion is going to be reintroduced after 15 years, and it's something they're going to pop and break. So,
I would agree with you, Don.
Yeah.
And a problem that my elderly patients have is falling. Find you guys up here.
Lots of people around here in the Don Sullivan Show. Just coming by to say hello on as we're cruising up and down the Rhine. So, and we're going past I have to digress for a minute because this is what I do. This is really quite incredible because it's like a huge medieval castle every 3 to 5 miles or whatever. But so back to our discussion, Dr. Theo. If I said that range of motion is the most important thing, the most important metric, and the most important capability that anyone can have at any age for injury prevention, would you think that I am speaking in hyperbole over making that point too enthusiastically?
No, I think that's very important. When I think of my patients who are aging, one of the metrics we use is frailty, and frailty has to do with how weak or strong, frailty, right? On how weak or how strong patients are, and of course that has a lot to do with their joints and their range of motion. And we also look at fall risk, and fall risk is something which can be deadly to an elderly patient because they snap a hip and they're in bed and they develop all the horrible things that happen when people are in bed. So physical therapy, since we're talking about that, is very helpful when it comes to enhancing balance. Balance. Did I say balance? Balance is a very important thing as people age because it is when people have difficulty with balance that they fall. And so along with enhancing one's balance, you also, with physical therapy, can enhance their strength because if they're weak, they're much more likely to fall. And of course, range of motion. So as you mentioned, Don, physical therapy can be a major preventive medicine tool to help anyone of any age. But of course, with my elderly population, I am much more aggressive about getting them to engage in physical therapy as a preventive tool.
But I also would say that from a perspective of real lifelong maintenance, the approach towards flexibility and range of motion optimization and all proactive cares are incredibly important for the present youth, especially the youth or the younger people in America that still don't eat particularly well.
I would definitely agree. Most definitely.
So what's going on with the insurance companies? I have experienced that they generally do not embrace the idea of optimizing proactive care in general, physical therapy being the one I'm most sensitive towards. And you're obviously you're on the front lines of all of this, and you're very successful, as you mentioned, when necessary, doing peer-to-peer types of accelerations or taking the discussion to the next step to get approval. Do you think I'm wrong about the attitudes of the insurance companies? I'm just overly sensitive about it, or?
Well, I would say this, and this is speaking from my own clinical experience. When it comes to physical therapy, I typically do not have any difficulty with an insurance company getting them to approve it, because it turns out physical therapy, the number of sessions you have is going to certainly
usually it's about 30 a year. It's in a standard marketplace plan of some kind.
Right.
Getting them approved, getting a prescription, but getting them approved. You can give prescriptions yourself, right?
I can give prescriptions
as
myself.
A GP, not necessarily as an orthopedist.
Right. No, I mean, I often do that outside of consultation with an orthopedic surgeon or a neurosurgeon, because it's usually going to be one of the two when it comes to low back pain. Other joints, of course, like your shoulders or your hips or your knees, that's definitely going to fall in the realm of the orthopedic surgeon. But when it comes to the back, there's usually two types of surgeons. There's an orthopedic back surgeon, and then there's a neurosurgeon. So typically, insurances will cover physical therapy, and they will cover that far sooner than they will cover an imaging study such as an MRI. In fact, there are many times that the insurance company will set forth an algorithm that says, hey, Dr. Hodge, you need to have done all the conservative management and the patient still be complaining before we will approve an imaging study such as an MRI.
So you really do think they're a lot more open to it than I necessarily have experienced. Again, I'm pretty sensitive towards this, and I'm also somebody who is such a proponent of it. And we were both, albeit a long, long time ago in a galaxy far, far away, we were both pretty renowned middle distance runners, and we have experienced this, these types of athletes on a global basis. So I am somebody who generally wants to see this. If I could have my way, people would be in physical therapy 3 times a week before they would before they're even hurt. But obviously that's a little bit too much. I tell you, go back to the 90s, it was much more common that month-long prescriptions were given.
Right.
And now they're a lot more strict about it, I suppose. But what you're saying to me is that if the doctor is proactive enough, and I'll ask you, my next question is this something that you were just more aware of because of your athletic athletic success and deep lifelong background than your peers are? Would all of your peers be as open and proactive as you are describing your own practice to be?
So I have to say that my patient population certainly, again, reflects my age. And certainly as a younger physician, people were they're still in the weight room, but so many of the injuries that I actually have walking in are not, well, they can certainly be dad helping his daughter move. But earlier in my career, it was because I'm in the gym and I lifted this and I lifted that, and I wrenched my back. It's a typical term I would hear from my patients. So physical therapy was something that was very prominently used from the very beginning of my career because patients had back pain or shoulder pain or knee pain.
But do you think that's because of your athletic background and success that you understood that as opposed to the broader medical community that your peers were?
So I think, certainly my athleticism back in the day, and it does seem like yesterday in so many ways, it certainly had an influence, as you would expect, on how I practice medicine. But I do think that the general algorithm of how you approach musculoskeletal concerns is prominent among any, general internists. That they would know that, and they would not be.
Well, they should know.
Right.
I'm not sure they do, at least at the level that you do, and that's what I'm really kind of debating here.
That could be the case. You would hope not. I mean, usually patients will call it to their attention, or they switch doctors. They're not getting what they want.
Well, they don't know what they want, though.
Well, that's many times they know.
What they want is a pill most of the time. Unfortunately,
they want it to be, for you to make it go away instantly, which is something that again the healthcare provider has to deal with.
You give cortisone shots?
I do not. That's where a specialist would come in. Yeah, would be involved.
Because so somebody's really got a problem, you send them to an orthopedist. Then I've had a lot of them, by the way. I guess you probably have too.
Well, that's actually the fourth part of the conservative management. You do anti-inflammatories, muscle relaxants, physical therapy, and if there's still an issue, that's when a specialist comes in, and I may do an imaging study, because after a certain period of time, if you're still having an issue, then I really do have to wonder, is there a surgical option that might be present? And if upon finding out that information, the patient is still hesitant, then this is usually I have them have a couple of opinions, because I'm never one to say, hey, the surgical option offered by this person that they should accept 100%. I'm like, yeah, let's get another opinion. But many times if they say, hey, I don't want to do a surgical option, but I'm still having this pain, and we've done all of this conservative management, is there anything left? The next thing for me is pain management, a pain management specialist. And that's usually where you will get, your corticosteroid injections or other types of injections that will help manage pain. So, as I said, that's a typical algorithm. I mean, of course, no one has to follow all the steps in order, and it's really patient-centered. So it depends on the patient as to how you're going to navigate that algorithm. But that's just a typical algorithm on how one approaches musculoskeletal pain, of which physical therapy is the linchpin. You cannot do anything without physical therapy.
That's where I wanted to get to exactly in this particular interview. And one of the things that I'll sort of end this up with, though, is to ask you, and again, this is a very difficult question, because we're at a certain point in our lives where we could easily be accused of being unacceptably old school, to put it politely. I find the younger physical therapists now to be much more sensitive towards costs, much more sensitive towards things that are something other than the athletic training that's really necessary. They basically just want to get people in and out as much as possible. And I know, for example, I've been to I've had well documented on the Don Sullivan Show, I've had a number of different surgeries. I've had a lot more in the past, and I have decided not to work with more physical therapists than I have completely. And I will tell you that I work with Brad, particularly Brad, who has been on the show. I work with him very specifically because he is a real old school athletic trainer, and he knows how to beat me up when necessary, and it is very, very clear with me. And I'm not totally seeing that and it may again be my own experience or my own oversensitivity and just not trusting the younger generation. I'm also seeing that they, overall, again, back to the insurance companies are paying less per hour and requiring a lot more detailed, specific documentation before the insurance, before the physical therapy companies or the individual physical therapists get paid. So am I overstating any of this, you think?
No, not at all. I mean, in fact, in terms of reimbursement, we often have to create templates based on what we know insurances will require to be documented prior to completing a note and submission to the particular insurance company, because they will definitely reject if there's certain elements that have not been documented. So we have to be very careful when we actually are documenting our treatment plans. And that certainly applies to physical therapy, which is why I get this detailed assessment from the physical therapist.
As it's called.
Right, but with the physical therapist, they usually will send me a detailed assessment of what they want to do, over what period of time they want to do it, and how many sessions that will occur in that period of time, which then I have to sign, because if I don't sign saying that I agree with it, then the insurance company will say, hey, the primary care physician did not agree to this, and they will reject it. So it's all very important in terms of correct documentation. And yes, we are being asked to provide more and more and more. Did I say more? More documentation.
It's like, clearly, I know this, but you're spending some ridiculous, probably 25% of your time doing that documentation and doing that insurance company validation and justification even of your overall time as opposed to spending it with your patients. And that's a whole different problem for a whole different discussion and so on. But it really applies so much to physical therapy because it's almost you need a billing specialist that understands so many different codes and exactly how to fill out the proper forms and so on, or you wind up getting into a vicious cycle of reimbursement or lack of reimbursement that really makes your overall approach to, as a patient or as a practitioner, whether it's a physical therapist or a provider or a doctor, to become just less effective and so on. So, and what I'll say is this: is that clearly, without getting into anything that I really shouldn't, would I ever do that? But there is an overall philosophy with certain companies, as opposed to others, of delaying as much as possible and making it more difficult to actually complete the paperwork you need to get properly reimbursed or even approved. And a lot of times the patients and even the doctors will walk away from it because of that.
Unfortunately, very true.
All right, I think that's enough for today, as we are sitting going past another castle or palace or something. We're working on our first world problems, 0th world, if we're in Silicon Valley, maybe. And so we have to end this episode because we have to go to lunch. So thank you, Dr. Theo, again for another visit on the Don Sullivan Show, and we will have you back very soon.
All right, it's an absolute pleasure. Thank you, Don.
All right, folks, and remember, no matter what I'm doing, where I am in the world, whether I'm in these ridiculously luxurious places talking about physical therapy myself, or whether or not I'm in much more difficult conditions, leaving a large mountain in very bad shape, or climbing up and down the Grand Canyon. Remember one thing that's the most important thing for me to get across to you. Remember that all at-bats are situational.